Welcome everyone, and thank you for joining us today for Vaughan QI Grand Rounds. Our topic today is using the NICU wisely. Our presenter today is Dr. Erica Edwards, and Erica is the Director of Data Science here at Vermont Oxford Network. Our guest discussants are Dr. Renata Savage and Dr. John Zapanzik. Renata is the Professor of Pediatrics and Chief Neonatology and Newborn Services Division, Department of Pediatrics at Children's Hospital of Mississippi. John is the Associate Professor of Pediatrics at Harvard Medical School, Associate Chief of Neonatology at Beth Israel Deaconess Medical Center in Boston. Our Vaughan faculty panel today include Dr. Jeffrey Horbar, Dr. Roger Saul, Dr. Danielle Errett, and my name is Denise Zayak, and I'm your host today. So we want to invite you to discuss and chat throughout our presentation. So let's just walk through this together because I'm going to change my settings along with you. So we want to make sure that you chat to all panelists and attendees. So if you navigate to the bottom of your Zoom screen, you'll see a little comment bubble and it says chat below that. So just click on that. And then at the bottom left of that screen, you're going to see that there's an address to, and just double check and make sure that you have that set to panelists and attendees. That'll mean that all of your colleagues can see your comment as well as all of our faculty who are on the special panel with us today. Here's our agenda. Erica will open by giving us some background and data about choosing wisely in newborn care. She will then transition us to a discussion with your excellent faculty panel today. We'll then hear the second part of Erica's presentation, which will focus on understanding variation and the impact of preference-sensitive care. Erica will then lead us through the second part of the discussion and Q&A, and then we'll wrap up at the top of the hour. So it is my extreme pleasure to now pass the baton on to Erica's presentation with great thanks, and I know you're going to enjoy and find this presentation very inspiring.
The United States spends more on healthcare than any other country, with costs approaching $4 trillion annually. Waste in the healthcare system is estimated to cost $760 to $935 billion annually, or 25% of all healthcare expenditures. 3 of the 6 domains of wasteful care identified by the Institute of Medicine reflect what we will discuss today. Failure of care delivery includes things like inefficient clinical processes or redundant testing. Failure of care coordination includes unnecessary admissions. Overtreatment includes low-value medication use, screening, testing, or procedures. Together, these 3 domains comprise $205 to $345 billion annually, or 1/4 to 1/3 of all waste. The Choosing Wisely campaign promotes a national dialogue on avoiding overuse and misuse of medical tests, treatments, and procedures. To identify overuse and misuse in newborn care, a national survey was conducted that identified over 1,600 tests and over 1,200 treatments that could be reduced or eliminated. An expert panel of 51 people representing 28 perinatal care organizations reviewed and culled the list through 3 rounds of a modified Delphi process. After the 3 rounds, the expert panel identified these 5 items that could not be adequately justified by efficacy, cost, or safety. We proposed that equally important to choosing wisely is using the NICU wisely and asking which infants are being admitted to your NICU, how long are they staying, and why are they there? We looked at these questions using the Vermont Oxford Network database of all NICU admissions. We evaluated utilization among nearly 500,000 infants at 381 hospitals in the United States by calculating the proportion of admissions, initial hospitalized days, high acuity admissions, and short stays by gestational age and by NICU type. To answer the question of which infants are being admitted to your NICU, We evaluated the proportions of admissions by gestational age, asking what proportion of admissions at each hospital were in each gestational age category. The gestational age categories are listed at the top of the chart. The box plots illustrate the range of the proportions of NICU admissions at the hospital level. The line in the box plot is the median proportion. The bottom of the box is the proportion at the 25th percentile, and the top of the box is the proportion at the 75th percentile. The whiskers represent the minimum and maximum values. So, for example, the median proportion of a hospital's NICU admissions that were very preterm infants, or those 26 to 29 weeks gestational age at birth, was 5%, meaning that at half the centers, the proportion of admissions that were very preterm was more than 5%, and at half it was less than 5%. At the maximum, 46% of NICU admissions were very preterm infants. And the median proportion of a hospital's admissions that were term infants, or 39 to 40 weeks, was 24%, although at the maximum, 44% of NICU admissions were term infants. To answer the question of how long are they staying, we evaluated the proportion of initial days hospitalized by gestational age. Preterm infants, or those less than 30 weeks gestational age, represented 30% of initial hospitalized days, while term infants, or those at least 37 weeks gestation, represented 21%. Overall, infants stayed nearly 10 million days during their initial hospitalization from 2014 to 2016. At a rough estimate of $3,000 per day, these NICU admissions cost over $28.9 billion, or over $9.6 billion per year. Based on the number of births in the United States and an average NICU admission rate of 10%, we estimated that our sample represented approximately 40% of NICU admissions. Under these assumptions, the approximate cost for initial hospitalizations for infants admitted to NICUs may be around $24 billion per year, although the rough estimate of $3,000 per day is from 2010 and is likely an underestimate. To answer the question, why are they there, we adapted a definition of high acuity admissions used by Joe Shulman and colleagues in California for infants who were born at least 34 weeks. The definition included the outcomes listed on this slide. The proportion of NICU admissions that were at least 34 weeks gestational age in the VERMONT U.S. expanded population of 74% was nearly equal to the 79% observed in California. The proportion of high acuity admissions for infants at least 34 weeks gestation in the VERMONT U.S. sample was 15%, which again was nearly equal to the 11% observed in California. We also estimated the proportion of initial hospitalized days consumed by these high acuity infants at 21%. We were surprised to learn that high acuity admissions were such a low proportion of admissions. Said another way, 85% of NICU admissions for infants at least 34 weeks gestational age and 79% of the initial hospitalized days were not high acuity. Not surprisingly, the proportion of high acuity infants varied by NICU type. At centers with restrictions on the amount of time they can ventilate infants before transferring them to a higher level of care, the median proportion of high acuity infants was 6%. At centers that do not have ventilation restrictions but do not do surgery, the median proportion was 8%. At centers that perform surgery, except cardiac surgery requiring bypass, the median proportion was 12%. And at centers that perform cardiac surgery requiring bypass, the highest level centers, the median proportion was 37%. You can see the tremendous variation by NICU type in the proportion of admissions that were high acuity, ranging from 0% of infants to 100% at some centers. But even at the highest level NICUs, 63% of admissions for infants at least 34 weeks gestational age were not high acuity. We also looked at short stays of 1 to 3 days to answer the question of why are they there. We found that 10% of infants who were at least 34 weeks gestational age had short stays of no more than 3 days. The median proportion of infants with short stays ranged from 12% at centers with ventilation restrictions to 5% at the highest level NICUs, and from 0 to 30% at the center level. We're going to stop here for now and take questions and discussion, and then return to learn about how quality improvement can be used to address using the NICU wisely. So while we wait for our panelists to unmute themselves and come back on video, I just want to remind everyone that if you'd like to send us questions, you can chat them to all panelists and attendees. But I'd like to start with a few questions, and particularly I'd like to start with Renata, who is now at the University of New Mexico, and she has switched sites from Mississippi. But Renata, I was wondering if you've observed these same trends in the NICUs where you've been practicing in terms of the numbers of admissions and distributions.
Yeah, again, it really strikes me how each individual NICU decides what they will manage in their NICU versus what they might manage in a level 2 that might be nearby versus what might be admitted to their well nursery. Things like short-term oxygen, things like hypoglycemia. It really is so variable, and I think there is really good evidence that we need to look at the evidence. Can many of these babies be managed in a lower acuity unit, saving cost, but how would those units look? So again, in Mississippi, we were always so full with high acuity babies that we increasingly, over the time I was there, expanded our level 2 and had many more admissions of these types of babies to our level 2 nursery that was in the same hospital, but really saving a lot of money and not admitting them to our NICU. Now, again, finances goes into, are people willing to not have those babies admitted to their NICU? But I think developing a robust level 2 with maybe not necessarily neonatologists or having a carve out could really take a lot of those babies away from the NICU and save costs.
Mm-hmm. And John, are you observing the same? In fact, John, I know that you've published on short stays at your NICU, so you've obviously observed some of these same trends.
Yeah, that was actually quite a long time ago, the triage and short stay information. So I think it's actually something that is, partly a trend, but it's also partly I guess a trend in our awareness of this problem. And it's interesting that you brought up choosing wisely, which is really application of evidence to a problem of value, I guess, and using the NICU wisely, which is essentially an issue of a lack of evidence amongst a particular group of patients. We don't know a whole lot about what to do with babies of lower illness acuity. And so as neonatologists, I think we apply what we do to 26 weekers of high acuity, which is that we start to over-manage them, and we keep them under our close, extremely close monitoring in a very high acuity center. So I understand what you were saying, Renata, about the evidence. I think that's true, but it's not the traditional kind of evidence. And generating that, I think, will be helpful in reassuring us that babies who have feeding immaturity can be managed someplace other than a level 3 or level 4 center.
Yes, Dr. Pantoja from Colorado had commented, have you seen a variation through the years in the number of low intensity admissions related to management of well-appearing infants admitted just for antibiotic treatment, is what he said choreo infants. And I'm wondering if, that need to manage those low intensity admissions and not necessarily having another place to do that is driving much of what we're seeing.
Was that for me, Erica?
Yeah, or whomever.
Yeah, I think your comment brings up this an issue of classification too, right? What we call a well baby nursery or couplet care or postpartum unit, what we call a level 2, has a very broad definition, and so I think in this example, many places consider IV antibiotics to be part of what happens in a well baby nursery, and other places do not. So defining by function, I think, is going to be something important. The evidence thing also comes into this question of antibiotics, because it's not only where we manage those, it's the fact that the application of evidence over the past few years with antibiotic stewardship and calculation of sepsis in a more nuanced way has really driven down the number of babies who are exposed to antibiotics, and therefore pulled them back into where they should be, which is with their moms.
Mm-hmm. So I don't know, I know where John practices, that's almost all inborn infants, and Renata, I'm sure where you practice, there must be a mix of inborn and outborn infants. Jeff Myers had asked, of the data that we were looking at, how many of the patients were inborn, and he said, my sense is that the structure of the spectrum of well baby care to NICU care impacts this observation. And we haven't looked at it in terms of inborn and outborn, but there must be some differences in the patterns that we see of utilization, depending on what proportion of outborn infants you have in your unit. Is that your sense as well?
Yeah, certainly for the places that I have worked at have been level 4 NICUs with a high transport service for surgery. But I think we also need to be mindful that many states do not have other NICUs. I mean, again, it's different in Boston, where every other corner might have a NICU, and there are many NICUs throughout the state. But in many rural states, there is a pediatrician and a well baby nursery throughout the state. And then if that baby is at all sick, needs IV antibiotics or needs some oxygen, they get sent very quickly. So I think that's also a challenge for us. We need to be cognizant of the big difference between states and how they manage babies that might be 200 miles away, but the pediatrician just cannot stay up all night because they have a clinic the next day. And whereas I think at some of the other states with very high acuity NICUs, they may only get the sickest of the sick. And then inborns might also be higher acuity. So again, I think when we look at the data more carefully, we really need to parse out what each state is referring to their level 4 NICUs and why. Mm-hmm. I think that can also be a big driver of cost.
Mm-hmm. And Michelle Bailey brings up the issue of transfer and who pays for transfer. And there have been some interesting articles on that have looked at the state-by-state laws of which states have will pay for referral of transports and which Medicaid will cover transports. And that will obviously play a major role here. There's also been some conversation in the chat about the infants with NAS and NOWs, and how our management of them has really changed as well and moved towards the newborn nursery. And that it came later than our paper, so maybe we would see a difference. I don't know, we haven't looked at that.
One can almost argue that admission to the NICU may be mismanagement of the child with NOWs in the day and age of Eat, Sleep, Console, where we are taking away our ability to deliver appropriate care.
Mm-hmm. John raised it earlier, the issue of the best place for the baby is with the parents. And I think in addition to the financial cost, there's a really a major cost to the family from that separation that needs to be considered.
So, oh, go ahead.
I was just saying the trend with many places to have in the NICU single family rooms instead of the large, pods, which even though they're in the NICU, they do now allow the mother to stay with the baby. and whether places are doing that now, if there are more single family rooms in NICUs, even though you like to not have to admit a baby with NOWs to a NICU, if there could be some designation that might drive those costs down, to have that baby stay with the mother, because unfortunately most OB postpartum places, peds wards, don't have the ability to have the mother stay there for a long time. Be interesting to see what's going on across the country with NOWs, since it's not going away anytime soon.
There's some interesting conversation in the chat about training, residence training and fellow training. And I know that this is a topic of interest for all of our panelists. So someone was saying that with current residency training, many general pediatricians are not experienced or comfortable in managing simple neonatal problems. And then somebody else commented that teaching the fellows is part of their teaching for their fellows is the importance of not treating short-term stay infants for things like hypoglycemia or TTN. And that seems to be there seems to be a real push-pull there. If the residents are not comfortable and the fellows are trying to keep the infants with their mothers, how do we try to resolve that? What's the best way to go?
I think that it's possible that that's a vicious circle. You know, if we've defined a certain population of patients as needing NICU care, then people feel uncomfortable providing that care. It seems to me that if we're taking an approach of, you know, right place for the right baby at the right time, that besides level 3, 2 at a well baby nursery, there's also couplet care with mom, and there are certain groups of patients who belong there. Many of those patients, just because they're babies, may not be any more sick than the infants and children parents are looking after at home after they leave the hospital. And yet we've defined away this population as being part of the purview of the NICU until they get discharged home. So it seems to me that if you can kind of undo that definition, then residents will get exposure, they'll get experience, they'll realize this is not critical care, this is well, you know, or pediatric care, and it's what they should be training to do. But absolutely, there's a transitional period and variation between institutions that is going to contribute to people's comfort.
There was another question also about this activity that's going on now in terms of the designation of NICU levels of care and what role that will be playing in all of this as we move forward. Has anybody on our panel gone through that process of looking at the designations of the levels of neonatal care in your state?
It's my understanding at this point only Texas is requiring it. I think it may be a trend, and I think my understanding, and you know, someone else may have more information, is it's not so much to really designate as opposed to say, if you want to be a level 4, this is what you need to have, and if you don't have it, this is what you need to do to bring it up to that level, as opposed to saying you might think you're a level 3, but you're really a level 2. So, you know, I think many places are trying to sort of quote unquote upgrade themselves a little bit so they can care for higher acuity, though they may not have that ability. But, you know, I think as a subspecialty, we do need to look more at having the right baby in the right place. And, you know, we do have a lot of these short stays that we are so sure they need to be under our care, and maybe they need to be have oversight by neonatologists, but not necessarily in the NICU. And maybe we can help the pediatricians and the pediatric residents or the hospitalists care for them a little bit better and keep them with the mother.
Mm-hmm. And someone's also saying, from a nursing perspective, we've lost the nursing specialty of mostly well newborn care. The baby must be perfect to keep with mother-baby units. And Roger was seconding that by saying, what about adequate support and education for nursing staff as well as for the residents and fellows, which I think is another fascinating observation. And again, I would ask the panelists to comment to see if they've observed that as well.
Well, I wonder if part of that is also that mothers are sicker than they used to be. We know that the health of mothers is going in the wrong direction. And I wonder if the mother baby nurses are feeling more stressed because they're having to care for sicker mothers and are saying, I just don't have time to care for this baby who might be the least bit sick. I wonder if that's part of the trend that plays into it, because we certainly have had pushback from mother baby units. You're right, the baby's the least bit sick and they are told they can't take care of them in that mother baby unit. But I also know in Mississippi that mothers were god awful ill sometimes and on the regular floor. I'm interested in what others' experiences have been in that sense.
Well, whether sicker or less sick, Renata, I do know that support of the mother-baby diet and the intense effort that goes into adequate support there leads to a shift of focus and priorities. And I think that Robin's comment about, a kid who's even anything but completely well gets shunted off in a different direction, unfairly to the family and burdening the system.
Yeah, somebody made a great comment. Danielle, you will appreciate this. In some countries, in low and middle income countries, there are mother baby units with better trained nurses to care for such babies. And I know from your global experience that you've seen this.
I have, and if those of you tuning in today haven't seen the recent immediate kangaroo mother care trial published in the New England Journal of Medicine, I think that's an excellent example of this couplet care John was talking about, truly having a mother newborn unit. And I think that's an excellent example of how we really can, in high income countries, learn from a great model of care that's being practiced in low and middle income countries. I think there's a lot to be learned from that, and a lot of benefit to both mom and baby. We don't practice that yet in Vermont. That would be my dream, but I think something to learn from.
I find this, the idea of the transition towards that kind of interesting, because it often comes, the comment that was made earlier often comes up that, the nurses are too stretched to provide higher acuity care, because they have more patients than the NICU might, or the level 2 might. In economics, we say that everything's variable in the long run. And if we have humility about wanting to provide care to a population of patients in the right place, then pulling resources from a NICU and placing those resources into adequate nursing personnel in a different part of the hospital can create a system of care that makes more sense. And I think often there are these walls that are put up that, here's the budget for the NICU and here's the budget for the well baby nursery, and that creates an obstacle to care. So I think it's possible to take some of these big ideas like the kangaroo mother care or lesser degrees like couplet care, for example, and put them into place if we in the NICU say, okay, it's time to do this. I think more revolutionary way, I suppose.
Well, on that note, I think it's time for our next short presentation. And this one talks a little bit about what some centers are doing to address this issue of using the NICU wisely. So we can come back to this idea.
John Winberg provided a framework for understanding variation in healthcare. Effective care includes services that, based on reasonably sound medical evidence, work better than any alternative and for which the benefits exceed any side effects or unintended consequences. Supply-sensitive care refers to services for which utilization rates are sensitive to the availability of healthcare resources, such as beds or physicians. Preference-sensitive care is driven by patient or physician preference and includes interventions for which there is more than one option and where the outcomes may differ according to the options used. We're going to spend today's time by talking about preference-sensitive care, which is shaped by medical opinion, scientific evidence, and patient or family preference. Because patients, or in the case of newborns, parents, usually delegate decision-making to doctors and other members of the care team, medical opinion and scientific evidence, rather than patient preference, often determines which treatments patients receive. Practice style turned out to be a primary driver of NICU utilization in an online survey conducted by the American Academy of Pediatrics, National Association of Neonatal Nurses, and Vermont Oxford Network. In this survey, we provided clinical scenarios about the location or duration of care as seen here, and we asked, in your hospital, what currently happens during this scenario? And in your opinion, what should happen? So for example, a preterm infant delivered for maternal indications has APGAR scores of 9 and 9 and is well appearing in the delivery room. In your hospital, what is the lowest gestational age at which this infant would be admitted directly to the well newborn nursery by policy, guideline, or practice? And in your opinion, what is the lowest gestational age at which this infant should be admitted directly to the well newborn nursery? If there was a difference between what respondents reported currently happens and what they thought should happen, we asked to what extent each of these factors influenced unit practice: inadequate staff or space, medical legal considerations, payers, and concepts of preference-sensitive care, including medical literature, professional society guidance, local practice, and family requests. The rank order of factors that, to a large extent, influence the difference between what currently happens and what should happen are listed here. You can see the high influence that local practice played in decisions about location or duration of care. Our sense is that practice style, or the way we've always done things, drives much of care and probably influences who gets admitted to the NICU and how long they stay. Dr. Wenberg does not explicitly discuss the role that standardization, in the form of unit policies and guidelines, can play on practice style and whether standardization could reduce variation in preference-sensitive care. Standardization of care is an important component of quality improvement and of neonatology generally. In fact, QI methods, including standardization, is one of the key drivers used by teams in the Vermont Oxford Network Clinical Transitions Quality Improvement Collaborative. The work of this collaborative seeks to ensure that all transitions in an infant's care meet the Institute of Medicine's STEEPS criteria of being safe, timely, equitable, effective, efficient, patient and family-centered, and socially and environmentally responsible. At the beginning and end of each year in the collaborative, teams complete an audit of unit policies and guidelines around communication, standardization, teamwork, and family integration. These charts represent the proportions of policies at the hospital level. At the first audit, the average hospital implemented 47% of the policies reflective of good communication, 70% of the policies reflective of standardized practices, 67% of the policies reflective of good teamwork, and 50% of the policies supporting family integration. Some audit questions about policies and guidelines addressed who is being admitted and how long are they staying. 92% of units reported having a policy about which infants get admitted to units. Fewer units had policies for addressing the medical stability and clinical status for adequate weight gain, thermal control, respiratory control, and feeding. Only 65% of units reported having a process to engage families in planning the transition to home. To evaluate whether your unit is meeting the STEEPS criteria and using the NICU wisely, start with the question, who is being admitted? You can use your center's admission book or perhaps an EHR report. Centers in the Vermont Oxford Network database of all NICU admissions can use Nightingale to view the number of infants admitted by birth weight or gestational age, and see a list of infants as well as individual infant reports. Once you've assessed who is being admitted, you can ask, why are they there? And start taking action to reduce unnecessary admissions. I spoke with Dr. Susan Bedwell, a neonatal clinical nurse specialist and director of quality improvement in the section of neonatal perinatal medicine at Oklahoma Children's Hospital. Her unit has implemented several great ideas for using their NICU wisely. First, they review all infants who are greater than 35 weeks at birth and are admitted to the NICU, or who have short stays. They implemented a respiratory algorithm for infants greater than 35 weeks who have mild respiratory distress after birth that is administered by specially trained transition nurses that resulted in a significant decrease in admissions. They eliminated NICU admissions for infants greater than 35 weeks with hypothermia. And as part of their work in the Critical Transitions Collaborative, they instituted an algorithm that has reduced hypoglycemia admissions to only a few a month. You can see a poster of their hypoglycemia project in the Improvement Library in the Vermont Oxford Network portal. Another critical transition related to using the NICU wisely is discharge preparation, to work on how long are they staying. These ideas also come from teams participating in the Critical Transitions Quality Improvement Collaborative. Cedars-Sinai Hospital in Los Angeles is holding discharge preparation meetings at 32 weeks corrected gestational age and has developed specialized materials for families with complex discharges like tracheostomy. Betty H. Cameron Women's and Children's Hospital at New Hanover Regional Medical Center in Wilmington, North Carolina, is holding weekly discharge education meetings via Zoom and has created standardized discharge to home checklists. The Greater Baltimore Medical Center is making discharge planning part of every infant's rounds every day. And many centers have created new visuals showing the pathway to home, which is a great way for everyone to begin with the end in mind. Finally, I'd like to talk about areas for future research, taken from a recent review article by David Braun and colleagues called Choosing Wisely for the Other 80%. To address supply-sensitive care, we need to understand the total birth cohort, including infants not admitted to NICUs, to help define appropriate health service areas, newborn and perinatal provider networks, and referral systems. We need to understand what resources are available at a hospital, health system, and community level in order to determine where infants should receive care. We also need to understand the types of units to which babies are admitted and the impact that those different types of units have on outcomes such as mortality, morbidities, length of stay, and cost. To address effective care, we need to know more about the more mature newborns who are being admitted to NICUs. We need to develop a minimal data set to evaluate those admissions to understand who is being admitted and why. And although we have focused on overuse, there may be underuse too. We lack good studies on NICU readmissions or primary NICU admissions for term infants who were previously discharged home. To address practice-sensitive care, we need to identify and evaluate existing practices, policies, and interventions that result in NICU admissions. And while hospitals are good at standardizing care within their NICUs, there is little standardization across NICUs, starting with the assignment of levels of care. If you are interested in this topic, here are some suggestions for additional reading. In particular, I recommend a recent issue of Seminars in Perinatology, edited by Dr. John Sapanzik, focused on economic considerations in neonatal intensive care. And with that, it is time for more discussion. So again, while we have people coming back, if you would like to chat in a question or a comment, please do so, and please choose all panelists and attendees. So one of the things that I really enjoyed the most about doing this presentation was learning about what centers are doing to use the NICU wisely. And I was wondering what you thought about the ideas that were being posted, and if you have other ideas for centers to apply quality improvement to this question. Either John or Renata or any of our panelists, please feel free.
While Renata's working on that, I really enjoyed the article by Brana et al. And I think creating, as a, not just piece by piece, but at creating a structure of research and quality improvement, and to try to address it, I think is really sound. Vermont Oxford has created the main structure that we use for analyzing these things, and for a long time we concentrated on the smaller babies in as a community. But as with the foresight to expand that to larger babies, it's allowed us, to allow our community to examine issues like this. And I think taking it to the next step of ensuring that we have information about follow-up and leveraging the better availability of data at state levels, for example, or in systems, will let us move to the next step, because there are so many holes in the data and typically what we say is, well, this is worrisome, this is not safe, and we have nothing to reassure us about it.
Renata, do you want to try again?
Yeah, I wonder if, I think I fixed it now. I wonder if some of the pushback has been the recent information about the late preterm or the early term baby, and that they are sicker than people thought in the past. And so I wonder if that caused some of the increase in these admissions, that we might have thought, oh, they're just fine. And then the data saying, no, they really do have more jaundice, more feeding problems, and maybe we needed to pay more attention. But I have a question for you, Eric. In preparing this presentation, if you wanted to give advice to a level 3 unit, what would be the low-hanging fruit, the areas that they should focus on to start being more effective using their NICU wisely? It's hard to do all of these things, but where would you advise people start?
Well, so the 3 main components, I think, of using the NICU wisely, the first one is to start by understanding who's there. And so starting with the data that you have. Joe Schulman, who has been providing some great comments in the chat, thank you, Dr. Schulman, is pushing folks to look at your logbooks, get an EHR report, just to understand the distribution of the infants that are being admitted, how long they're staying there, and why they're there. And the why they're there, I think, is probably the most challenging part. And I know that in California, he is now asking centers to voluntarily collect data on admission diagnoses, and especially for the older infants, so that they can start to get a sense of why infants are being admitted. But then I was very impressed with the work from the Oklahoma Children's Hospital on how they've managed to identify the problems, and then one by one come up with solutions, including this idea of having specially trained transition nurses. And that's all they do is help during that transition process. So there are other comments about, this idea of, is it really fair to call it a NICU anymore? Or should we be thinking more broadly about a newborn comprehensive care unit, which is one of the ideas that Dr. Schulman brought up. But then somebody else commented, and I wanted to get people's thoughts on this, about acceptable risk. And how much risk is acceptable, and who wants to accept that risk?
Well, one of the classic paradigms for that is our use of the EOS calculator. Okay, and we have a strong agenda to become better stewards of antibiotics, and we've been extraordinarily successful in the application. but it shifts a risk. It demands more resources in following that child up in settings we're not as familiar with. And this, I think, goes back to Jay-Z's comment, but we need to think about the whole system as we do these things and shift the responsibilities such that these risks are acceptable.
And, one of the, I hardly agree with that, Roger. I think that the sepsis calculator has really created a bit of a paradigm shift in how we think of very uncommon situations. And, it created a metric for it. It put a number on it, and we could see how small it was. And we completely transformed care for a particular population of patients at risk. And I think a lot of the situations we're talking about similarly have very low risks. A baby with jaundice, a baby going home with some irritability from NOWs. These are low risks. And I think maybe a practical point of this is to start figuring out a way to measure what that risk is and be able to present to our community, that the chances of a problem with this population of patients is only 1 in 500, and so how about this as a standardization? I think it's difficult to know how to get from here to there, and what Vaughn has done for many years is give people data, and then they can start to take it forward. So maybe that's what we have to do, more of the sorts of work that you're presenting today.
Somebody made an interesting comment that is something that I've been thinking about a lot about too, which is standardization and cutoffs. So they said, I'm setting a gestational age criteria of less than 35 weeks to be admitted to the NICU has pros and cons. And should it really depend more on the developmental maturation of the infant, rather than just saying, this is our line, and above this, they're fine, and below this, they're not. I did practicing neonatologists. Do you have any thoughts on that?
Well, I think it also speaks to how poorly we do transitions in our units. Transition, as you pointed out, the families aren't ready to have the babies go home necessarily. We don't do a good job with that. We do a very poor job generally in communicating with the pediatricians who are going to be caring for these babies. I think that's an area that's really ripe for improving how neonatologists interact with the world outside of our NICU. And I think, that could shift the risk a lot if we have better systems in place for families to go to if there's a problem coming back. I know one of the things we instituted in Mississippi was having a well baby check within that first week, coming back to the well baby nursery once they've been discharged. And we did have some admissions from there, but it really cut down the serious admissions from readmission and really helped us to see that the babies were feeding well. Again, it was a bit of effort to get the hospital to agree to it, but just doing some simple things like that really can help a lot. And again, those were better well baby nursery babies, but it did help a lot, just sort of thinking outside the box a little bit.
Erica, you're not going to get me to speak out against standardization, but it reflects a little bit of John's point, though, about risk. You set the standards at a risk criteria. So if any baby less than 37 weeks gets admitted, we know that's absurd. But why 35? Why not allow for an area of judgment with parents and counseling? We do this around issues of viability all the time. And I think we'd all agree that the 30-weekers are coming to our unit. So I would argue this is as much whether we do thoughtful standardization. And you're not going to catch me speaking that the standardization is the problem here.
I think that thoughtful piece is very interesting. There's a comment here about 35 weekers, and what the folks did who developed the sepsis calculator was to use something more than fever, yes or no, and to start looking at things in a more nuanced way. So how about a trial of monitoring for a 35-weeker? If you're mature, then you go someplace else. So I think we can standardize with precision and nuance. And the problem with standardization, I suppose, if if there is one, is that if it's done too crudely, then you might be making the problem a little worse.
There may also be an issue somebody has mentioned with from where are these guidelines originating, and the input of professional organizations mentions guidelines for hypoglycemia from the American Academy of Pediatrics versus the Pediatric Endocrine Society. And that actually goes back to our Using the NICU Wisely survey. What of the pieces of medical advice, medical legal considerations, and just, what we've always done is going to play a role in who eventually gets admitted. I want to talk before we're almost out of time, and I want to talk really briefly, or not briefly, because we could spend a whole hour on this, on the elephant in the room, which is finances. And this is specific to the United States, so I apologize to our international colleagues, but a few people have brought it up, and what role reimbursements for NICU admissions or for mildly ill infants might be playing in all of this. Renata, you're nodding.
Well, I think for all of us that have been division chiefs, we know how much the finances of the NICU not only run the children's hospital, but run the entire hospital often, that it is a big source of revenue for the hospital. And so I think finances are a critical part. And I don't think we have paid enough attention to the finances in the NICU of being cost effective and how that cost savings comes back to benefit those of us that are taking care of babies if we are more cost effective. I think that would be a ripe area. It's certainly something we need to be teaching our fellows a whole lot better, teaching junior faculty. But it certainly is a tough issue. And, if we were to become capitated, we would be a money loser in many ways. So I think we need to be careful what the future of medicine is bringing in the United States. Right now, we're sort of the golden goose, but that could change very quickly. And I think we do have a lot of inefficiencies in our NICUs.
I would underline that, Renata, that we've been allowed to develop those inefficiencies because of payment models. Those payment models are changing probably more profoundly outside of pediatrics and outside of neonatology, but they're going to change for us too. And back, many years ago, when Vermont Oxford was thinking about value, people would often come with these examples of how revenue had dropped because of standardization that was done for important patient goals, and what we used to tell people is, I think we have to start to redesign our end of the system, looking at low-hanging fruit probably, but start to redesign our end of the system so that we are prepared when the payment models change to implement practices that provide better care to patients. So, even though a 35-weeker might be generating revenue right now for our unit, a well 35-weeker isn't going to continue to do that in 8 years or 10 years from now. And having processes in place where the RNs in the postpartum care unit are prepared to care for slightly immature babies, that would be a great thing to have available for you when things change. So, I think value-based care is, something like 30% of the even the American medical system currently, and it's going to affect us eventually. So.
Yeah. Related to that, we didn't discuss as much how long they stay as we did who gets in. But Erica, I know you've recently reviewed data demonstrating that there's been an 8-day increase in the average length of stay for NICU infants pretty much at all gestational ages. And I think this certainly bears on the reimbursement models, and our finances playing a role there. Are these infants is there a plus to it? Are infants being better prepared to go home? Or is it really just the financial incentive is to keep them a little longer? I don't know. Unfortunately, we didn't have time to look at those data in detail, but they're quite striking that length of stay for NICU infants has gone up dramatically.
Certainly a
And
financial point, but it may also go back to Jay-Z's point about risk and what risks we're willing to accept in sending in kids home.
Although, you know, for many of these, like there was in the Using NICU Wisely survey, there was a great deal of variability, even for items for which there was significant perceived risk, I guess. So, for example, duration of monitoring after an apneic or bradycardic episode for apnea of prematurity, that ranged from 3 days up to even 7 or 10 days. So some portion of the population seems to be okay with a particular amount of risk and some portion isn't. And it seems that that's a place where we should be able to come together because we're all using the same data. It's just perception, right?
Well, with that, I think we have to wrap. So I'd like to thank our panelists, Renata Savage and John Zupancic, Roger Stahl, Jeffrey Horvath, Daniel Arrett, as always. And I'm going to toss it back to Denise, who has a few closing slides for us.
Thanks so much, Erica. And thank you for your thanks for everyone. I thoroughly enjoyed this session. And I know everybody who attended got great value as we speak thusly. So I just want to remind everyone that we will have another session coming up for Vaughan QI Grand Rounds in August. We will announce the date soon. My colleague Drew will be sending out information to all of you and to your colleagues to encourage you to attend. We have a wonderful session on uncertainty in the NICU, the case of bronchopulmonary dysplasia. So this is a session that we presented live in Chicago in 2019, and we had such wonderful feedback that we wanted to be able to share that with an even broader audience. So please join us in August. Our presenters for that session will be Dr. Roger Stahl, Dr. John Zupancic, and Dr. Eric Jensen. And we also want to let you know that we are hosting a virtual 2021 Vermont Oxford Network Annual Quality Congress. It will span a month. So we begin September 29th, and that will be with the NICU Quality Improvement Collaborative Homerooms on September 29 and 30. iNICU colleagues will be joining us on the 30th, and then on October 1st, we have a day dedicated to iNICU Improving Critical Transitions, and that's open to the NICU colleagues. We're then going to move on with a number of wonderful individual sessions. These are typically 1 to 2 hour sessions. Audits, the right tool to improve your practice. Case of the year, AAP Vaughan Scholars presentations, Jumpstarting Quality, separate sessions for foundations and advanced workshops, Improving Critical Transitions Plenary Event Day. I will give you more details on the next slide. So that'll be a full day of wonderful programming, and March of Dimes in Vaughan, Improving Life Beyond the NICU. Our plenary event day will occur on Wednesday, October 20th. You do need to register for this, and my colleague Drew will be sending out information to encourage you to register. We'll open with a welcome by Jeffrey, and then we're going to have a series of wonderful presentations on follow-up and follow-through and health equity, and then a series of presentations about clinical transitions that can all be improved by improving critical transitions. So these will be wonderful, and we really hope that you will join us for those. Much more details to come in on our website. You're also welcome to share your improvement stories with a poster in our virtual annual quality congress, and Drew has provided the link to that here as well. So I want to thank all of you for joining us today. Special thanks to Erica, John, and Renata, and to all of my colleagues in the woods of Vermont. Thank you. Have a great day, and we'll look forward to seeing you next month. Bye for now.